Should we start?
I think so.
Good evening, everybody. Today we are going to discuss a very important topic because cardiac sarcoidosis, and it's important because the diagnosis is often missed. And if the diagnosis is missed, it is associated with severe sequelae and risk of sudden death. So today we will have initially an introduction by Dr. Narasimhan, followed by cardiac MRI and PET by Dr. Vishnu and Dr. Sunita, and Dr. Mutaya will then discuss the therapy. Now I request Dr. Narasimhan to give his talk.
Thank you very much, Dr. Bahel. And I would like to thank the Heart Failure Association of India for the kind invitation. Sarcoid heart disease, I just give an overview. And as the chairperson rightfully mentioned, it's a difficult diagnosis, but has serious prognostic significance. It's much more common than we think. We used to once upon a time think sarcoid is uncommon in India, but it's fairly common. And the delayed diagnosis increases both morbidity and mortality. In fact, undiagnosed terminal heart failure, when they go for LVAD and transplant, the core biopsy has revealed granulomatous or sarcoid myocarditis in as high as about 15 to 20% in unselected population. More importantly, is a disease of remission and relapses, just like multiple sclerosis or whatever it is. So it needs close supervision, and you need to kind of follow up the patient and titrate the therapy. But most important, it's a missed opportunity on the part of the physician to prevent serious ventricular dysfunction and fatal ventricular arrhythmias. So appropriate diagnosis, timely diagnosis and treatment can not only prevent fatal cardiac arrhythmias, but also prevent terminal heart failure in several of these patients. Over the next 12 minutes or so, I would talk about when to suspect cardiac sarcoid, how to diagnose, how to manage this disease entity, and speculate about what is the possible cause for cardiac sarcoid, which presents as isolated cardiac sarcoid. This is a Venn diagram which shows of the frequent clinical manifestations in cardiac sarcoid. The first manifestation of sarcoid can be an aborted sudden death. And very often, in fact, repeatedly autopsy series have indicated that sarcoid cardiac involvement often remains unnoticed and gets picked up only on autopsy. AV block, unexplained AV block can be a manifestation of cardiac sarcoid, progressive heart failure, ventricular arrhythmias, frequent PVCs. And one of the things we have noticed is ischemic mimics. Patients, I'm sure all of you would have seen patients who present with chest discomfort, mild LV dysfunction, mild troponin leak, and a regional wall motion abnormality. And you do an angio, and angio is near normal. And then we label it as recanalized LAD or slow flow or something. And that is a typical manifestation of ischemic mimic of a cardiac sarcoid. We have seen, in fact, Mutaya is putting together a series of this kind of presentation. So it can be asymptomatic and subclinical in several of the patients who present to other specialties. For example, patients who present to pulmonary clinic with pulmonary sarcoid, or patients with eye clinic with iritis can have subclinical cardiac involvement. Why is this important? Because what kills the patient is not the iritis, but the fatal arrhythmia. So failure to recognize this at that stage can be a serious issue. And as I said, we looked at a series of patients with unexplained AV block, not the very elderly, not the young. And when you look at unexplained AV block, our series indicates that approximately a third of these patients have an underlying sarcoid. Why is this important? Because failure to diagnose the underlying sarcoid and just implanting a pacemaker, these patients come back with frequent ventricular arrhythmias or even progressive ventricular dysfunction. And we often try to think that this is pacing-induced LV dysfunction. So this is an important entity not to be overlooked. Monomorphic VT, pleomorphic VT. Whenever you have an unexplained dilated cardiomyopathy in the absence of family history, so if your family history is negative and you have an unexplained dilated cardiomyopathy, you need to suspect this disease entity, especially if there is focal outpouchings like idiopathic LV aneurysms or focal outpouchings. ARVC is a known mimic of cardiac sarcoid. It's a phenotype. Sarcoid can present like ARVC, and a rare phenotype we have seen is like a HCM-like presentation. Also, you have unexplained mitral or aortic valve regurgitation as a manifestation of sarcoid. And as I said, ischemic mimics can be the presenting manifestation. So how does a clinician suspect an underlying sarcoid? What are the physical signs which helps you to diagnose? I'll go through this: ECG, echo, imaging, and biomarkers. I would like to again emphasize serum ACE levels in our series of over 200 odd patients remains elevated in less than 9% of patients with cardiac sarcoid. Proven cardiac sarcoid, the sensitivity is very low, and so please do not rely on ACE for making a diagnosis. We still continue to do this as a prognostic marker and use for follow-up, but for a diagnosis, ruling in and ruling out, it's not very useful. When you have past history of a patient being treated for tuberculosis and comes back with LV dysfunction or ventricular arrhythmia, you need to think of sarcoid. Presence of past history of Bell's palsy, skin nodules, adult onset respiratory disease, restrictive obstructive disease, or unexplained PAH, recurrent redness of the eyes can all be the presenting manifestation of sarcoid. The phenotypic variations are plenty: bronchial airway involvement, cutaneous involvement, dactylitis. You can have focal skin lesions, of course, midseptal scarring, and you have punched out lesions in the fingers, and myositis responsible for unexplained pain in these patients. Characteristic hyperpigmentation of the tattoos are also known manifestations. Now, as a cardiologist, the common garden simplest investigation we see is the ECG. When you see bundle branch blocks on the ECG or a fascicular block in the presence of an unexplained LV dysfunction, you should suspect sarcoid. Second thing is this fractionated QRS. When the QRS shows a notching within the high frequency notches within the QRS, you should suspect cardiac sarcoid. This is an entity we described a couple of years ago. One of our postgraduates, our fellows wrote this up. In contrast to beat-to-beat morphology remaining the same in a monomorphic VT or a continuously changing polymorphic VT, in patients with inflammatory cardiomyopathy, you have distinct PVCs of 2 or 3 morphology concurrently going. So you can see morphology 1, morphology 1, morphology 1, second morphology here, and a third morphology, but it repeats itself. It's not a true polymorphic VT, but a pleomorphic VT. So spectrum of ventricular arrhythmias in patients with sarcoid includes idiopathic monomorphic VT and PVCs, pleomorphic VTs, ventricular tachycardia with high-grade AV block. We have now recognized unexplained channelopathy-like presentation in the absence of family history can be a presenting manifestation. Of course, VT in the presence of valvular heart disease, ARVC, and advanced heart failure. This is a patient who was referred for catheter ablation But just seeing the pleomorphism of the VT, varying morphology and varying cycle length, made us suspect that this is an ongoing inflammation, which was confirmed by a PET imaging. And then we just stopped the ablation and treated this patient with immunosuppression. Because Dr. Raghu is unable to join today, I'm going to talk briefly about this. The frequent sign is a basal septal thinning or some degree of akinesia in the basal septal region should make you suspect this is sarcoid. The other common area that is involved is the posterobasal area or posterolateral area, where there is a thinning or akinesis, which should make you suspect of cardiac sarcoid. So once you suspect, we invariably get, in most patients, we get a cardiac MRI and a PET CT, because that helps us to either confirm the diagnosis or helps you to target the area of a biopsy. In a developing country like ours, where there's endemic for tuberculosis, it's extremely important to rule out tuberculosis, which can very closely mimic sarcoid. And as I said, serum AS levels, while it's useful to follow up the patients, but it's not very useful to make a diagnosis. Broadly, most of these patients you should exclude tuberculosis before proceeding with further treatment. So this is a typical example. Patients will come with unexplained AV block, pacemaker is implanted, and then this patient comes back with LV dysfunction, and we think it's pacemaker-induced LV dysfunction. Device upgrades to CRTD, but at that time, the biopsy confirms it's sarcoid. But after that, everything is gone. They have multiple admissions for heart failure, which culminates in death. So this treatment algorithm, because Dr. Muttaya is going to address this, I'll omit this. But just a brief speculation. Why is it we are seeing more and more of isolated cardiac sarcoid? So all of us know that whenever there is an antigen, the body tries to get rid of the antigen. But if the antigenic substance is too large and the macrophages are not able to clear the antigen, they wall the antigen around by a clustering of lymphocytes and macrophages. And that forms a granuloma, whether it's a foreign body granuloma, suture material, TAL granuloma, it's all very similar. But digested bacterial products and, for example, catalase protein in the mycobacterial proteins can also incite a granulomatous reaction, and that can lead on to a progressive granulomatous reaction. So the underlying hypothesis is such of us who are genetic propensity to develop granulomas, certain high-risk HLA markers, when an antigen gets into the myocytes, it causes a progressive unchecked granuloma formation, and that results in probably an isolated cardiac sarcoid. This was very well worked out by my colleague, Dr. Muttaya, where we looked at patients with prosthetic dental implant in patients who are prone to develop sarcoid, seems to predispose to development of cardiac sarcoid. So you need a two-hit hypothesis, genetic predisposition and exposure to the antigen, which could probably result in this. I would like to thank all my colleagues without whom this work is not possible. To run a sarcoid clinic all the time, it's quite a dedicated work. And I would like to conclude by saying AV block, ventricular dysfunction, and VT can be the manifestation of cardiac sarcoid. But please remember, in our country, we should exclude myocardial tuberculosis, which is a close mimic of cardiac sarcoid. And as I said, several clinical, electrocardiographic, and imaging clues are there to aid diagnosis. Early disease-specific therapy controls the arrhythmia, prevents ventricular dysfunction, and it's probably prevents the onset of a serious dilated cardiomyopathy. I would end there, and thank you for listening.
Thank you, sir, for a very concise introduction to the topic. I think the most important thing is to suspect sarcoidosis. So dilated cardiomyopathy or non-ischemic dilated cardiomyopathy is extremely common. And few factors you said where you should suspect sarcoidosis: heart blocks, arrhythmias, or outpouchings. What about the remaining dilated cardiomyopathy patients who do not have any of these typical features? Would you screen them for sarcoidosis or not?
Yes. So now we are started a study of prospectively looking at all comers of unexplained heart failure. We are looking for presence or absence. So the answer is I don't know. It's possible that it's likely that the prevalence of the disease is less in this subpopulation, but we are going to look at it prospectively. I don't have the answer at this juncture.
Right. Thank you, sir. Any questions? Anyone from the audience has any questions? Uh, I would request everyone to post. If you have any questions, please post them on the chat box. And now I would request Dr. Vishnu for his presentation on MRI and cardiac sarcoidosis. Can we have Dr. Vishnu's presentation, please? I think it's a recorded presentation. So if you can start the presentation.
Yes, doctor. Yes, doctor.
Thank you.
Good evening, everyone. In this brief talk, I will be talking about imaging features by which you can suspect cardiac sarcoidosis as a probable cause of heart failure.
We are not able to see the.
Sarcoidosis is a multisystem disease with granulomatous inflammation in the affected organs as the main pathognomic feature, and its cause remains unknown. Cardiac involvement in sarcoidosis is clinically seen in about 5% of
We cannot see
patients
the slides,
of
please.
sarcoidosis,
We just hear
but
the
the
voice.
autopsy series have shown that the involvement can be
Can we
as
stop
high
this
as
presentation
25%.
and
Yes.
go back to only audio is coming up?
Cardiac sarcoidosis and how it manifests. The three principal
Dr. Mutaya to finish or?
Yes. Okay, so it's come
It's
up.
come up. You can start the presentation.
Sir, before the presentation
Sir, it's
starts, okay. Why do you think the basal septum is involved in sarcoidosis?
Actually, there is no answer. I don't know. What we realize is there's probably some predilection for lymphatics in certain areas. And because this tends to be macrophage mediated, I don't know whether there's enriched. Because what we find is whenever there is an involvement, the posterobasal goes to subcarinal.
Everyone.
And the other one goes
I
to
will be talking
precarinal.
about imaging features by which you can
I
suspect
think the presentation is
cardiac
started.
sarcoidosis as a probable cause of heart failure. Sarcoidosis is a multisystem disease with granulomatous inflammation in the affected organs as the main pathognomic feature, and its cause remains unknown. Cardiac involvement in sarcoidosis is clinically seen in about 5% of patients of sarcoidosis, but the autopsy series have shown that the involvement can be as high as 25%. Coming to cardiac sarcoidosis and how it manifests, the three principal clinical manifestations of cardiac sarcoidosis are conduction disease in form of heart blocks or bundle branch blocks, ventricular arrhythmias as VT or VF, and then in advanced cases, the patients can present with heart failure. The presence of non-caseating granulomas on endomyocardial biopsy is the current gold standard for diagnosis of cardiac sarcoidosis. But however, as we all know, it is not practical to do this procedure, especially when the yield is very, very less. So in this scenario, cardiac MRI can have a significant role in identifying the cause of cardiac sarcoidosis being cause for the heart failure. And it has been successfully used as a diagnostic and prognostic tool in cardiac sarcoidosis. It is very good to identify sarcoid infiltration and scarring, and it is also reasonably good in detecting associated early acute inflammation with newer imaging techniques like T1 mapping and T2 mapping techniques. This slide is a gross overview of the different sequences that we have in our armamentarium to image the heart in evaluating a case of heart failure. And you can see the bottommost rows talk about T2 mapping and T1 mapping, which are currently being used as optional tools, but I believe in the years to come, these can become the mainstay in identifying early stages of inflammation, as well as identifying diffuse fibrotic changes in the heart. So coming to the features of cardiac sarcoidosis on cardiac MRI, the mainstay or the main sequence which is helpful in identifying or detecting cardiac sarcoidosis is late enhancement imaging. So the features which are more consistent are intense signal of late gadolinium enhancement or LGE, and prominent involvement of insertion points with direct and contiguous extension across to the right ventricle to the septum. So the intense enhancement as shown in this image with the contiguous involvement of the adjacent right ventricular wall, this pattern of enhancement, intense, multifocal, and extending to the RV through the insertion sites, is said to be a very specific pattern of enhancement in case of cardiac sarcoidosis. When this late enhancement technique is used in combination with the edema imaging using one of the newer parametric mapping sequences, our specificity to identify sarcoidosis can be increased, or sensitivity can be increased. Now let us look at two case examples of a typical sarcoid presentation. The first is that of a 36-year-old male with syncopal attacks, whose echo was unremarkable except for some septal bounce or uneven contraction. So a cardiac MRI was asked to assess the patient. So immediately on the short axis cine, you can see the septum being little less mobile than rest of the left ventricle, and the ejection fraction or the contractility remains preserved. These are the short axis stir images, or what we call edema images, to look for any areas of myocardial edema. And here you can see increased signal intensity in the septum, in the mid and basal slices, suggesting focal edema. Subsequently, a contrast enhanced image taken after 15 minutes of contrast administration is showing intense gadolinium uptake or gadolinium enhancement in the mid myocardium of the mid and basal septum, which is corresponding to the areas of the edema on stir sequence. And this patient also showed few enlarged mediastinal nodes in the prevascular region. Subsequently, a PET was asked, and PET also showed intense FDG uptake in the interventricular septum as well as the lateral wall. It is important to note here that the cardiac MRI did not show any enhancement or edema that well in the lateral wall, whereas PET is showing uptake in the lateral wall, inferior lateral wall. PET was also showed uptake in the mediastinal nodes, which were later biopsied, and they found non-caseating granulomas. Hence, the diagnosis of cardiac sarcoidosis was established. Coming to the next case, this is a case of 64-year-old male who had slow onset breathlessness and palpitations with syncopal attacks, and the ejection fraction was reduced on echo, and the coronaries were normal, and hence a cardiac MR was asked to evaluate for any cardiomyopathy. So the short axis cine sequence, you can immediately notice dyskinetic segments in the inferior wall of the right ventricle, as well as the basal interventricular septum. And you can see generalized reduced contractility of the myocardium. These are the late gadolinium enhancement sequences, which are showing multifocal areas of intense gadolinium enhancement involving the mid-myocardium, epicardium of the lateral wall, interventricular septum, inferior insertion sites, which is seen to continuously involve the inferior wall of the right ventricle as well. And in addition to the myocardial enhancement, you can also notice intense enhancement of the pericardium adjacent to the lateral wall. So this pattern of enhancement with additional involvement of the pericardium also indicates an inflammatory etiology. The same findings can also be seen in the four-chamber view, where you can see intense pericardial enhancement, epicardial enhancement extending into the mid-myocardium of the lateral wall, as well as the mid-myocardial enhancement of the septum. This patient also had multiple enlarged mediastinal nodes, as shown in these images on MRI. And subsequent PET CT, which was done, showed only two small focal areas of FDG uptake, very mild uptake in the septum as well as the lateral wall. So this was again proven to be a case of cardiac sarcoidosis by lymph node sampling. So that's how cardiac MRI can help us by way of characteristic appearances of the scar as well as the adjacent pericardial involvement, along with areas of edema, if seen together, help us to identify a cause being sarcoidosis. Cardiac MR is also useful in following up of patients of cardiac sarcoid. Here, these are two different scans done 2 years apart after the initiation of therapy, and you can see the regression of enhancement seen in the first scan on the subsequent scans in the basal septum and the mid inferior wall. You can see the enhancement has regressed. So this shows all the enhancement that we see on cardiac MRI need not be scarred areas. They can be granulomatous infiltrates, which can show intense enhancement. Only when these enhancement areas persist into much later stages and accompanied by thinning of the myocardium, we can call it as scarring on MRI.
Thank you. Thank you for a very concise presentation. So I have some questions. Can you differentiate what are the features which will differentiate it from tuberculosis? And the second thing is, what do you think are differential diagnoses on MRI? I mean, other conditions that can resemble sarcoidosis.
It is practically not possible to differentiate between the sarcoid and tuberculosis based on imaging features alone, because they can show similar pattern of enhancement, both being inflammatory cardiomyopathies. Based on purely imaging criteria, it's not possible to differentiate. We can maybe say they are granulomatous inflammation, which could be either tubercular or sarcoid. Both of them can show this type of intense multifocal enhancement. One other condition which can mimic sarcoidosis in a later stages are ARVD, especially when it is biventricular form, which we are seeing off late quite often than what we used to earlier. So they can also have this typical areas of epicardial enhancement, extension into the right ventricle, areas of dyskinesia, but usually they don't have edema along with them. They don't show areas of edema. So when we find areas of edema in form of increased signal intensity on stir sequence, as well as any pericardial inflammation along with the enhancement, we can raise suspicion of sarcoid being more likely than the ARBC. And again, in ARBC, you have other features like other areas not showing enhancement can have dyskinesia, microaneurysms can be seen. Apart from that, any fulminant viral myocarditis, they can also sometimes show a pattern of multifocal intense enhancement, but the clinical presentation usually will be a little different. They usually don't have lymph nodes. So these three sets of findings, like multifocal intense enhancement with the enlarged mediastinal lymph nodes, they usually tend to think or lean us more towards the granulomatous inflammation.
Thank you. Any other questions, please? There are no questions in the chat box, but anyone else would like to ask some question? So if there are none, thank you very much for a very concise presentation. And now we go on to the next talk by Dr. Sunita on PET in sarcoidosis.
Good evening. Thank you for giving me this opportunity. Today I will be talking about the role of PET-CT in cardiac sarcoidosis. So my topic will be on indication, patient preparation, which is a crucial, image interpretation, diagnosis and prognostic performance of this FDG in cardiac sarcoidosis. Is there any role in treatment response evaluation, and also what are the various novel PET radiotracers available? So as we all know, heart uses a mixture of fatty acids and also glucose for energy production. So there is a variable FDG uptake at resting conditions. So patient preparation is quite critical in order to detect myocardial inflammation. It comprises three types, that is prolonged fasting or dietary manipulation or intravenous heparin, or often in combination. Several studies show the major advantages and disadvantages of a combination of all these things, but expert committee recommends a structured protocol which combines a high fat, low carbohydrate meal and prolonged fasting with a compliance reinforcement, means detailed instructions is given, and to ensure once the patient comes to the department whether the patient followed the dietary protocol or not, and a 12 hours fasting. If there is any doubt, this patient can be planned for intravenous heparin injection 50 international units 15 minutes before the injection time. So two sets of images are acquired. First is a myocardial perfusion imaging, either with the technetium labeled radiopharmaceuticals like MIBI or tetrophosphine, or PET imaging radiopharmaceuticals like ammonia or rubidium, and F18 FDG images. If CT coronary angio or conventional angio is normal, then we can avoid this myocardial perfusion imaging. So this is the protocol which we follow in our department, but we follow a dietary restriction for 48 hours followed by 12 hours overnight fasting, rest images followed by FDG images. If and a dedicated cardiac images are acquired. If there is any high clinical suspicion for extracardiac sarcoidosis, then we do limited neck, chest and upper abdomen images also to see if there is any mediastinal and upper abdominal lymph nodes. So during the interpretation, there are two types of interpretation of the images. First is visual and the other is the quantitative method. The most common one which is used worldwide is the visual interpretation. It is interpreted patterns of uptake are 4. That is, there is no uptake, either diffuse uptake, focal uptake, or focal and or diffuse uptake. Let's see how it will be in the imaging. See, the left side images are the perfusion images, right side images are the FDG images. Perfusion is normal, but there is no uptake. This is the perfect preparation of the patient, no uptake. Next is diffuse uptake. If there is a diffuse FDG uptake, the preparation is not good. Next is focal uptake. Perfusion is normal, but there is a focal uptake. This is an abnormal, the uptake which is indicative of the cardiac inflammation. Next, focal on diffuse. This depends upon the patient preparation of the and also the expertise opinion. So focal or no uptake, it is considered as appropriate, and whereas the diffuse or the focal on diffuse is inappropriate preparation. So depending upon the degree of mismatch between the perfusion and FDG, there are four categories. In stage 1, normal perfusion and no FDG uptake. Stage 2, that is mild or early disease, the perfusion defect is mild with a mismatched FDG uptake. In a case of moderate or progressive disease, the perfusion defect is moderate to severe with corresponding mismatched FDG uptake. In the case of scarred or severe disease, severe perfusion defect is seen with no uptake. So here the normal perfusion with no FDG uptake, that is a normal scan, there is no cardiac inflammation. In the mild disease, there is a mild perfusion defect with a corresponding mismatch FDG uptake. In a case of moderate disease, there is a moderate perfusion defect with FDG uptake. In a case of severe or fibrotic disease, both perfusion and the myocardial uptake will not be there, that is FDG uptake will not be there. So several quantitative parameters have been described, but no supportive data is there. But one study which is performed in India by Subramaniam et al., they have identified the predictors of clinical and echocardiographic response following the immunosuppressive therapy in patients with cardiac sarcoidosis. So they have come up with one parameter, that is uptake index, which is a product of SUV max, that is standardized uptake value. It is a semi-quantitative parameter, and also the number of LV segments involved. So if the more number of segments are involved and the SUV max is high, then the prognosis is good. That is, these patients have predictable clinical and echocardiographic response. And this study conclude that pre-treatment FDG uptake is a predictor of both the clinical response and also echocardiographic response. So as such, this treatment response, there is one study done by Osborne et al., which included 23 the patients, and they showed that serial FDG is quite useful to know whether the patient is responding or not. In our hospital, we regularly follow the patient using the FDG, whether they are responding or not. To summarize, FDG, the use in cardiac sarcoidosis, the diagnosis is challenging and endomyocardial biopsy has low yield, and so FDG is included in HRS criteria, that is heart response, the HRS criteria. And combined perfusion and FDG helps to differentiate the pattern of disease, and patient preparation is the critical in this case. So, but it has its disadvantages like poor preparation, the interpretation is difficult if it is a diffuse, focal on diffuse. So, several new other tracers have come up to whether they can be used apart from the FDG. There are several radiopharmaceuticals, but the main disadvantages is availability. Most of them are not available in India. The only one which is available is radiolabeled somatostatin analog. C11-methionine, it requires on-site cyclotron because the half-life is C20. C11-methionine is done in few centers. Coming on to somatostatin analogs, the major advantage is there is no physiological uptake, and also there is no patient preparation. As such, false positives are less. So, but the literature is less. Only 2 studies have come up. One is done by the Lapa and colleagues. They have compared MRI with the DOTA and showed that there is a consistency, their concordance in 96% of the patient. Another study done by Gomson et al., they have done in the same patient both FDG and DOTA, and they showed that the diagnostic accuracy of DOTA is around 100% compared to 79%. So there is no prospective trial with a large number of patients to prove that DOTA is good or equally comparable with the FDG. But it is a promising alternative whenever there is any poor complaints from the patient, or if the patient cannot be prepared, or if the patient is sick. This is a good alternative. So let us see a few examples. This is a focal on diffuse uptake, which may be interpretation wise it is difficult. Whereas these are lower images, these are the maximum intensity projection images. These are the fused axial images. There is the pathological uptake in the basal interventricular septum, and the MIP images shows the uptake extracardiac sarcoidosis in the form of involvement of lung. Next is, please remember, isolated basal lateral uptake is a normal variant in the literature. So to conclude, current data for the non-FDG radiotracer is discussed in limited studies, and a large prospective study is needed in the future to further ascertain their potential. Thank you.
Thank you for a very clear presentation. Now, I have one question for you. What is the sensitivity of a PET scan? Supposing the PET is not suggestive of cardiac sarcoidosis, what is the sensitivity in the sense, what are the number of cases that we miss? If we say that the PET is normal, can we assume that it's not sarcoidosis?
Yes, negative predictive value is high, provided the patient preparation is good.
Any other questions? Dr. Narasimhan or someone in the panel would like to ask some questions?
I think Sunita has been very actively following up several patients simultaneously doing PET and MRI within 48 hours of each other. And to our surprise, we realized we have been missing some of the patients of cardiac sarcoid. And gallium DOTA scan has been much more sensitive in picking up the diagnosis, and the false positives have come down because this patient having a glucose uptake because of poor preparation goes off from the equation.
So we have started a prospective study in the same patients. We are doing both FDG and DOTA. Around 45 patients, the scan is done and the results are awaited. Means we are under the process of analysis. So we will come up in a couple of months. Mostly till now, initial preliminary results, DOTA is equally or even superior to FDG. But let's wait for the analysis.
Right. So would you conclude that, let us suppose the MRI is not suggestive of sarcoidosis, or it's not, would you definitely do a PET scan in patients who have a high index of suspicion of sarcoidosis?
See, if there is a high clinical suspicion, better to do, because we are not replacing the MRI. MRI is complementary to FDG. So, but whenever if MRI is negative and the clinical suspicion is high, better to go ahead with FDG.
Right. Thank you. Thank you. Thank you. And now we go on to the next talk, that is by Dr. Muthaiah. Dr. Sunita, please stay with us because we have a lot of time for discussion at the end of Dr. Muthaiah's talk, and he'll be speaking on therapy.
Okay.
Dr. Muthaiah, please.
Thank you, sir. Can I have permission to share, please? Madam, are you still sharing the screen?
The event manager has to give you the permission to share. You can share
I
now.
have received the permission to share, so probably yours also should be there.
You cannot start screen share while the other participant is sharing.
Oh, I'd request Dr. Sunita if she can stop sharing her screen.
Yeah, okay. I'm okay now. I'm okay now.
Thank you.
On.
Thank you.
Thank you, Narasimhan sir. Thank you, Ajay Bal sir. So we'll be discussing about tailored therapy for patients with cardiac sarcoidosis. And the one thing that we have found over years when we have been treating these patients is we have to be very individualized in some of these therapies. And whether it's immunosuppression or treatment after immunosuppression, every patient's need changes when diagnosed with cardiac sarcoid. So a few of the important issues that we have tried to encounter and tried to solve is, one, creating a standardized immunosuppression regimen where we can offer the same regimen, at least initially, to most of our patients. Early identification of who is responding to that immunosuppression and who is not, because the earlier we are able to attack the inflammation, it's important. So if they're not responding to your first-line immunosuppression, how to change that and identify that is important. Differentiating between TB and sarcoidosis, I think, has already been spoken about in terms of management. Also, I'll be saying a few things, and management of refractory cases. So this is a story of a 50-year-old lady where you can see as a clinical presentation, and what Narasimhan sir had mentioned, you can have patients who come to you after a sort of delayed presentation. So the first presentation may not be cardiac. This could be a lymphadenopathy causing a vocal cord palsy. Next, an ophthalmic involvement. So the patient has already had an underlying disease for 3 years. And that's where, like Sunita madam mentioned, there's a role of an FDG PET. So FDG PET not only helps us establish a diagnosis of cardiac sarcoid, but it also tells us about the inflammatory load or the inflammatory burden that these patients have. And I'll come back to this later. And most of our patients, we diagnose confirm sarcoidosis based on the presence of inflammation in a heterogeneous matter that madam had discussed, plus a biopsy. This is most of the time we target lymph nodes because they're slightly more non-invasive. And if we find these lymph nodes are FDG avid, our pickup is slightly better, or an endomyocardial biopsy. So usually, as cardiac sarcoidosis is an inflammation on PET plus either a cardiac or an extracardiac biopsy. And our institutional protocol for immunosuppression, it has changed over the years. But right now, what we follow is once, let's say, a patient came like the previous patient, you have a PET picture that is suggestive of sarcoid, a clinical presentation suggestive of cardiac sarcoid, and a biopsy that is positive. We usually start prednisolone 0.5 to 1 mg per kg per day, or an equivalent dose of methylprednisolone. We tend to be more towards the 0.5 than the 1 mg per kg. And we will concurrently start the patients on methotrexate 10 milligrams per week. And depending on how they're tolerating the methotrexate, we may increase this dose up to 15 to 20 milligrams per week. So our idea of this high dose steroids is that we usually like to taper and stop these steroids over the first 3 months, or we'll usually even start tapering the doses as early as 7 or 8 weeks. And usually after 3 months, we'll repeat an FDG PET. So this initial repeat FDG PET is for two things. One, it is to identify whether this person is responding to our steroids with a reduction in FDG PET with a clinical response, or does the patient not responding? Is there no clinical response and no FDG uptake? And this differentiation is very important because this is what guides the rest of our therapy. So if you, let's say we had a patient who presented like the previous patient with a ventricular tachycardia, you've treated with 12 weeks, a repeat PET shows no myocardial FDG uptake. This is a responder for immunosuppression. So this is a clear-cut way to treat this patient. On the other hand, let us say ventricular tachycardia persists, and now there is no FDG uptake on the previous PET scan. So two things are possible. Either you have adequately treated the FDG uptake, which is unlikely because the patient still has ventricular tachycardia, or that the disease has now gone past the inflammatory phase, and now you've reached a burnt out stage of the disease. And in between, you can have patients where there is some reduction in FDG PET, not complete resolution, with plus or minus clinical response. So let us say that you have a real good responder. After 12 weeks, repeat PET is good. In these patients, we stop steroids and continue methotrexate for 2 years. If we feel clinical response is plus minus and there is some residual FDG uptake, we will either intensify the amount of steroids or add a second or third line agent, and we'll come back to that. If we feel the patient doesn't have any FDG uptake and there is no clinical response, we likely feel that this patient has run out a burnt out stage or a burnt out phase of sarcoid. And these patients, we look at advanced heart failure therapy. So this is our current protocol for immunosuppression in patients with confirmed cardiac sarcoidosis. So the protocol for follow-up is also very important. Initially, when we start steroids, we usually try to give vaccination for these patients before we start steroids. I'll come back to the ruling in and ruling out of tuberculosis, but we initially see the patients every 2 weeks. And the main reason is to look out for steroid toxicity in these patients. Indian patients are slightly more prone to develop these steroid-related adverse effects, whether it's weight gain or it's proximal myopathy. So it's important to see them very closely for the first 3 months and then every month thereafter. And the thing that Narasimhan sir has been doing from the beginning has made sure that it's a multidisciplinary approach. So we have a weekly sarcoid clinic where we're able to combine with the pulmonologist and rheumatologist. And this is important in terms of decision making because sometimes it may involve a dose adjustment of a immunosuppressive drug. It may alter an antiarrhythmic dose for a cardiology medication. There's multiple interactions here, and our confidence is higher when we do this as a team, and probably the patient's confidence is also higher. So once we start the patients on immunosuppression, how do we monitor the response? So disease activity, one, if these patients present with ventricular arrhythmias, we can look at the ECG, Holters, or the implanted device checkup to see if, for example, if the VT burden is the same or if it's come down. In patients who present with LV dysfunction and RW, regional wall abnormalities, we can look at the LV ejection fraction. We have found that in certain local areas where there is increased edema or inflammation, there is initially a lower tissue velocity. So as these patients improve inflammation in these local areas, their tissue velocities can also increase. So that is one side of monitoring the disease activity. Monitoring immunosuppressive adverse reactions are as important as these because these are often high-dose steroids that we're using for the first 2 to 3 months. So concurrent infections, muscle wasting, rise in blood sugars for patients especially patients who are already diabetic, and drug-specific adverse effects, even especially for methotrexate when you take it over a course of time. So these are some things that we consider when we start patients on immunosuppression. Now, assessing the response to immunosuppression is also very important, and this needs to be done earlier, as we have learned. So what we do is, like I showed you, after that initial 12 weeks, somewhere on the 4th or 5th month, usually, we repeat an FDG PET. And this is important because there are two things we're trying to assess here. Has the patient clinically responded? So is there a reduction in functional NYHA class? Is there freedom from the initial ventricular arrhythmias and heart failures? And if the patient presented with an LV dysfunction, is there an improvement in LV ejection fraction? So we divide our patients into either complete responders, where there is echocardiographic response, clinical response, and no residual FDG uptake. Non-responders, where there's neither clinical or echocardiographic response, and partial responders, where immunosuppression and the response to immunosuppression. So when we looked at our patients over our initial first close to 100 patients with cardiac sarcoidosis, what we found was that complete responders to this standardized immunosuppression regimen was more than 50% or close to 55%. Partial responders was close to 21%, but still, despite this intensive immunosuppressive regimen, still our non-responder rate was close to 24%. So this can either be due to patients presenting in different stages of the disease. So they were closer to, there was a higher scar burden, lower inflammatory burden. Second is they may have multi-organ involvement, or it may be that they were initially resistant to the initial steroids that were given. So these are the couple sort of options that we see with patients with non-responders. But what we've learned over time is you need to identify these non-responders early and sort of choose the next therapy quickly. So when you have some inflammation left to treat, you still need to treat them early. This is something that we published, and what we showed that was in patients, two similar patients. If you took patients who had an initial high inflammatory burden, and we define this as the amount of FDG uptake in the number of LV segments involved, compared to patients with a lower inflammatory burden or lower FDG uptake, the amount of patients who responded was more in patients who had a higher inflammatory burden. So patients where there is more inflammation to treat, if you identify them early and treat them early, their chance for a complete clinical, echocardiographic, and radiological response is higher compared to patients where there's more scar, lesser inflammatory burden left to treat. So that is important in terms of picking up these patients early. So how do we approach these refractory cases where we call them non-responders? So these patients, they will have some burden of ventricular arrhythmias. They will have some burden of heart failure. So if they have a residual myocardial FDG uptake on their PET, then we still try to hit that residual FDG uptake hard by sort of using second or third line steroid sparing agents, and now even the use of biological antibodies. Let us say there is no myocardial FDG uptake. Patient continues to have VT, LV dysfunction. There's no myocardial uptake. In that case, it is a burnt out phase. So here, sort of increasing the steroids, adding a second or third line agent is not going to have so much response. So in these patients, we prefer to sort of progress to advanced heart failure therapy options, either assist devices or transplant. This is a 35-year-old male, and this is a sort of a presentation where patient presented initially with ventricular tachycardia that is initially not responsive to any antiarrhythmics. Then subsequently, over the next few months, a diagnosis of cardiac sarcoidosis was made, but a combination of steroids, antiarrhythmics, ablation, all of these things didn't do anything to the ventricular tachyarrhythmias. In the end, we went to a third-line agent with adalimumab, and that is now something that we're doing more and more in our patients. And after starting biological therapies, there was a reduction in the VT burden and clinical response in this patient. So there is a role for these kind of biological agents, especially in patients who are steroid resistant or in non-responders to immunosuppression. So biological therapy is there. Main thing we need to watch out for in starting adalimumab or rituximab for these patients is the flaring up of underlying infections, and the most common being tuberculosis and other things. So you have to be extra cautious and make sure that TB is not, it is pure sarcoid and not TB, as I'll show you in the next few slides. because that is the important thing to differentiate when you start these patients on these strong immunosuppressive agents. So when you manage patients with ventricular arrhythmias with a cardiac sarcoid, again, it comes down to two things. Is the patient having underlying inflammation? Is the patient not having underlying inflammation? Narasimhan sir had mentioned regarding pleomorphic VT as a sign of inflammation. So if you have patients presenting with a pleomorphic VT, multiple morphologies of PVCs, FDG uptake has a strong myocardial uptake, then they are in an inflammatory phase. And in this inflammatory phase, and I'll show you in the next slide, the best thing to do is to intensify the immunosuppression. If you go after the ventricular arrhythmias with ablation, the response and the recurrence rate is higher in the inflammatory phase. Once they go into a scar phase and there's no FDG uptake, then it's somewhat similar to doing an ablation in a patient with a scar VT. So the response and the recurrence rates are, recurrence is lower in these patients. So this is how usually we approach patients with a ventricular tachycardia, make a diagnosis, go with an immunosuppressive regimen. If the patient is in an inflammatory phase, treat them with inflammatory drugs, antiarrhythmics, and an ICD if required. If patient does not have any myocardial FDG uptake and still has VT, then you go with a treatment approach with more antiarrhythmic drugs and ablation if required. So this was the outcomes that we showed, that in a patients who are having an inflammatory phase, the outcomes of ablation are less compared to patients who are in scar phase where the ablation is more successful. So this is what this shows here. Now, the last part of this talk, just 2 slides, is the main thing, and Dr. Ball had also mentioned, this differentiation between TB and sarcoidosis. In an endemic country like India, this remains very, very difficult because clinically and radiologically, they are similar. The only thing that we have on that to differentiate these two conditions really is serological tests and a few soft points in terms of histopathological differentiation. So the way we manage this is we routinely do a tuberculin skin test, interferon gamma assay. We'll do a gene expert and a TB culture from the tissue biopsy or the lymph node biopsy. If someone has a positive gene expert or a positive TB culture, we say that this patient has active tuberculosis and we treat them with a different regimen. Let us say that the T expert and TB culture are negative, but they have a skin test that is positive or interferon gamma assay that is positive. Then we say that this is latent TB. And this is how we differentiate these two groups of patients. And it still remains difficult. So if it's an active TB, what we do is a 4-drug regimen, INH, rifampicin, ethambutol, and pyrazinamide. And this is continued for 9 months, or at least the 2-drug regimen is given for, 4 drugs is given for similarly for 3 months. And then we'll do 2 drugs for 6 months. And we will only give 40 to 60% of the calculated steroid dosage. On the other hand, if it's a latent TB, we do a 2-drug regimen for 9 months and a normal steroid dose. And sometimes there's a lot of drug interactions, especially with rifampicin and our antiarrhythmic drugs. So we need to be a little careful when we start these medications, and especially for patients where, for example, they are on methotrexate plus these drugs, you need to watch out for liver enzyme elevation and liver injury as well. So our experience with TB myocarditis, we have published this. So following ATT and steroids, and if it is an active tuberculosis, this seems to work well, and this is a significant clinical and radiological response. In a few group of patients, what we have seen is that similar to other organ systems or an iris-like syndrome, when you start ATT to someone with the TB, there is a paradoxical reaction, or there's a paradoxical worsening of their current situation. So if it is a VT, they go into an exaggerated VT or a VT storm, or they go into an acute heart failure. And one of the hypotheses we had was that this is an exaggerated cell-mediated immunity response in response to the ATT. And in this state, usually we sort of intensify the immunosuppression, and usually the patients are able to come over this sort of paradoxical reaction phase, and they do well on follow-up. So this is something that is of note that we've described, we've seen in other organ systems, and we're finding this in myocarditis as well. So an early diagnosis is crucial, not only because the higher the inflammatory burden, the higher the success of immunosuppression. And if you hit these if you identify these people early and initiate adequate immunosuppression, the response rate is good. Differentiating TB and sarcoid is still a clinical challenge, and we need to still be careful and quantifying whether it's TB versus sarcoid. And tailored therapy is required for refractory cases. So I'll stop sharing. Happy to answer any questions.
Thank you, Dr. Muthaya. That was a very comprehensive coverage of the therapy. Uh, one question I have is, tuberculosis is always difficult to exclude. So what percentage of your patients get empirical ATT? And the second question is, if you are not able to establish a histological diagnosis and you have typical features of sarcoidosis, would you start steroid therapy?
Sir, so the first part of the question is, it still remains difficult, sir. But roughly from our patient group, we have this latent TB we are finding in more than 30 to 40% of our patients. And the sort of the double-edged sword here is, if you discount the latent TB, hit them with a full dose of steroids, there's a chance that if it is an underlying TB, that there will be a worsening of that disease. So that is one thing that we keep in mind. And the second part of your question, I'm sorry, sir, what was the second part? The non. So
in case you're not able to establish a histology and you have typical features on typical features clinically and on imaging, then would you start therapy?
Yeah, so the one way that is the one thing that really helps us there is looking for lymphadenopathy, sir. So let us say you have an FDG uptake that is positive, and let us say you have a clinical presentation of cardiac sarcoid. If it is only a FDG uptake without lymph nodes, we are slightly hesitant, sir. If it is lymph nodes are present, plus uptake, plus a clinical presentation, we're more confident to treat these patients as a sarcoid. Narasimhan sir can add anything if sir.
Yeah. Ajay, this is important. We are just putting this together. We find some of the LMNA mutations, some of the genetic cardiomyopathies have isolated focal uptake, mimicking sarcoid. But how we differentiate is absence of lymphadenopathy.
Right. Any other questions, please? If there are none, I would like to thank all the speakers and just emphasize some of the important points. Sarcoidosis, the most important thing is to suspect, and suspect. Unless you have a high index of suspicion, you will not diagnose it. And PET, CT, and MRI, one has to go for the typical clinical features. In addition to that, ECG, especially a patient with dilated cardiomyopathy and arrhythmias, on echocardiography, basal thinning and outpouchings, and typical MRI and PET picture. So suspect and diagnose sarcoidosis. I would like to thank all the speakers for a very lucid presentation. Thank you and good night.
Good night. Thank you.
Good evening, ladies and gentlemen, and a very warm welcome to this evening's webinar. As the incidence of rheumatic heart disease in our country has gone down over the past few years, the commonest cause is ischemic heart disease. So when we do angiogram and find out that the coronaries are normal and person is in heart failure, the diagnosis made is usually a cardiomyopathy, which could be either hypertrophic or dilated cardiomyopathy. If we exclude the causes like viral myocarditis or thyrotoxic cardiomyopathy, then most of the times these patients are labeled as idiopathic cardiomyopathy, and therefore they are put into one basket, which could have several conditions which are potentially treatable. One such cause is ATTR cardiomyopathy. And this webinar this evening focuses on ATTR cardiomyopathy, for which till recently no treatment was available, but now there is a drug available which can at least halt the progress of this particular condition, if not remove the underlying cause. This webinar is sponsored by Pfizer, and to discuss various aspects of this, we have a very eminent panel. So let me first invite Dr. J.C. Mohan, who is going to tell us about the red flags in ATTR cardiomyopathy as to when should a clinician start suspecting that the condition is amyloidosis and not just idiopathic dilated cardiomyopathy. Dr. Mohan, over to you.
Thank you, Dr. Chopra, and good evening to everybody. As Dr. Chopra pointed out, I would be talking about the red flags which should make you suspect that the patient may be having cardiac amyloidosis in the context of what you are seeing on imaging, ECG, or clinical picture. Here is the disclaimer. The views expressed here are my own, and Pfizer, our sponsors, are no way responsible for the views, and they may not agree with those views. Amyloidosis is deposition of fibrillar insoluble abnormal protein called amyloid in extracellular matrix of the solid organs, including heart, which causes organ dysfunction. This disease entity is under-recognized, underappreciated, and undertreated. However, this is an important treatable clinical entity. There are myriad ways of presentation of transthyretin amyloidosis affecting the heart. 2/3 of the patients present with heart failure. A good number of these individuals could present actually with all three phenotypes of heart failure. Mostly, of course, it is heart failure with preserved ejection fraction, but also heart failure with mildly reduced ejection fraction and heart failure with reduced ejection fraction have been well described in patients with ATTR. 5% of all patients who actually are diagnosed to have left ventricular hypertrophy of unknown cause or hypertrophic cardiomyopathy or even hypertensive heart disease actually turn out to be cardiac amyloidosis, largely ATTR. Patients who undergo aortic valve replacement for degenerative aortic stenosis in elderly individuals, anything from 5 to 16% of these individuals have associated ATTR, which affects the prognosis in a different way. Conduction disturbances are another red flag for ATTR. Isolated atrial fibrillation in elderly is an important red flag, and prior pacemaker implantation patients, if they present with heart failure, especially with thick walls, you should consider transthyretin amyloidosis. Here is a study, actually, a single center study of 100 patients of wild type of ATTR, just to show how ATTR presents in clinical conditions. Heart failure, 68% patients have heart failure, AV blocks occur in 7%. Features of hypertrophy on any of the imaging technique are present in 14%, and that is where the diagnosis is made as left ventricle hypertrophy of known or unknown cause. And 11% patients are picked up incidentally because either they had carpal tunnel syndrome or autonomic neuropathy. However, the important diagnostic mistakes which we make when we are ignoring ATTR, especially of the wild type, is we quite often diagnose this patient to a hypertensive heart disease because elderly people quite often have hypertension. And that happens in 35% patients. Hypertrophic cardiomyopathy, 24% of these patients are labeled as hypertrophic cardiomyopathy, but actually have ATTR. 9% of these patients are labeled as HFpEF, and without specifying the etiology, and these 9% patients have actually underlying ATTR. As I said, in aortic stenosis, about 9% patients, and pure restrictive cardiomyopathy, the variety which we commonly label as idiopathic restrictive cardiomyopathy, 3% of these patients actually still having ATTR cardiomyopathy. ATTR cardiomyopathy is underestimated because of absence of systematic screening, complexity of diagnosis confirmation, and overlap with other cardiac disease phenotypes. So what are the disease phenotypes which are commonly mistaken, or they commonly overlap the presentation of ATTR cardiomyopathy? These could be Anderson-Fabry disease, hemochromatosis, hereditary oxalosis, Friedreich's ataxia, Danon syndrome, and mucopolysaccharidosis. More common echophenotypes in cardiac amyloidosis are hypertrophic cardiomyopathy, hypertensive left ventricle hypertrophy, CKD, because CKD is not uncommon in patients with the amyloidosis, type 2 diabetes, where also hypertrophy can occur even without hypertension, and HFpEF in the elderly. So why talk about red flags? Because clinical red flags in the context should lead to imaging. And when you suspect ATTR on imaging, you would do biochemical tests to rule out AL amyloidosis and to look at cardiac biomarkers for prognosis. And finally, you will make an accurate diagnosis. So we will talk about clinical red flags, ECG red flags, biomarker red flags, transthoracic echo red flags, therapeutic red flags, and CMR red flags quickly. I know that Dr. Soumitra Ray is going to cover transthoracic echo, ECG, and CMR, and I will just breeze through these. Clinical red flags could be carpal tunnel syndrome, which can precede as much as 10 years, ATTR, peripheral neuropathy, macroglossia, spinal stenosis, biceps tendon rupture, deafness, premature pacemaker implantation in a young individual, chronic diarrhea, proteinuria, hyperproteinemia, nail dystrophy, easy bruising, and periorbital purpura. Carpal tunnel syndrome is prognostically also relevant. Not only it is 10 times more common in individuals who finally go on to develop ATTR, but heart failure is more common in patients who have carpal tunnel now, or they had carpal tunnel syndrome in the past. So it can easily be said that numb hands could be a window to the heart. Whenever you see patients presenting with numb hands, think of carpal tunnel syndrome and think of ATTR. The other important thing is that we treat a lot of patients of heart failure with all kinds of drugs. And if there is a poor tolerance of heart failure medications, especially in HFpEF patient, heart failure with mildly reduced ejection fraction, one should seriously consider that these patients could have ATTR cardiomyopathy. Autonomic neuropathy seen in amyloidosis often, and that produces inability to tolerate hypotensive treatments. Postural hypotension in heart failure may also be a red flag. As we also already mentioned, clinical diagnosis of aortic stenosis in elderly, whenever you make, remember that up to 15% of these cases may have associated ATTR cardiomyopathy, and simple TAVR or SAVR may not solve the problem of progressive dyspnea in these patients. And red flag should always be systematically searched for in low gradient, low flow aortic stenosis, where ATTR cardiomyopathy is relatively common. The other important thing in patient aortic stenosis is whenever you have disproportionate anti-pro-BNP or BNP levels or troponin elevated in absence of renal failure, think in terms of ATTR cardiomyopathy. When to suspect amyloidosis based upon ECG in a patient heart failure? As I said, Dr. Soumitra Ray will take you through that. But ECG showing old infarct patterns with low voltage, every case of heart failure with bundle branch block, Gold-Burgess triad, isolated atrial fibrillation, and even left ventricle hypertrophy by voltage in 10%, you should, once at least ATTR should cross your mind. Here is a typical ECG of an individual who has what you will call low voltage graph in limb leads and pseudo anterior wall infarction in the pattern of anterior infarction in the chest leads. So what you normally see is if you have done an echocardiogram and you find a discordance between wall thickness and ECG left ventricle hypertrophy, think of amyloidosis. Here is one of my own patients showing you typical low voltage graph in the limb leads and of course poor R-wave progression with atrial fibrillation. Remember, atrial fibrillation is present nearly in half of the patients with ATTR amyloidosis. Another patient with ATTR amyloidosis showing you a QS type of pattern, V1 to V3, old infarction pattern, and of course low voltage graph. Another patient, the ventricular hypertrophy, the voltage may not be always disproportionately low, and here is an example. Although a pseudo-infarct pattern in V1 to V3, voltages are adequate. This is called Gold-Burgess triad, which essentially means low voltage in limb leads, normal voltage in precordial leads, and poor R-wave progression V1 to V3. Commonly, these people have RV dysfunction in the form of positive T wave in AVR, as in this case. So ECG in ATTR may also include first degree AV block, non-specific interventricular conduction defect, second or third degree AV block, atrial fibrillation, ventricular tachycardia, and these all serve as red flag. At least once you should think, could this patient have ATTR cardiomyopathy? And especially in presence of atrial fibrillation, because here are 5 studies listed here where the wild type of ATTR has been shown to have atrial fibrillation in 27 to 62% of the cases, clearly telling us that when patient has isolated atrial fibrillation, think of ATTR cardiomyopathy, largely involving the atria, but also involving the ventricles. So the other red flag, whichever imaging technique you use, thick walled ventricle by any imaging technique demands respect of a clinician, and ATTR cardiomyopathy should be kept in mind. Here is a study showing that if the people are elderly and they have evidence of so-called left ventricle hypertrophy, if they're above the age of 80 years, 26% of them have ATTR cardiomyopathy, 70 to 79 years, 21%, and less than 70 years, 9% of these individuals have ATTR cardiomyopathy. Transthoracic echo red flags are many, and I think Dr. Soumitra Ray will take you through details. Low grade, low flow aortic stenosis, whenever you diagnose, think of ATTR. Left ventricle wall thickness more than 12 millimeter in presence of HFpEF, disproportionate low global longitudinal strain, apical sparing on acoustic speckle tracking, pericardial effusion with left ventricle hypertrophy, severely depressed LA reservoir strain, and lack of mechanical atrial systole on echo, you should seriously consider ATTR. So suspected ATTR amyloidosis when heart failure, patient have thick walls of the left ventricle, associated right ventricle hypertrophy, or any unknown left ventricle hypertrophy, or heart failure with, as I said, very low global longitudinal strain, besides, of course, the Gold-Burgess triad. Let me quickly show you an example of patient with this The right ventricle hypertrophy along with left ventricle hypertrophy and of course thickness of the atrial septum, classic feature of cardiac amyloidosis. The sparing of the apex is also called cherry on top appearance on acoustic spectral tracking, and normally these individuals have very low global longitudinal strain but pretty good, reasonably good ejection fraction, and that ratio more than 4 of ejection fraction to global longitudinal strain is quite suggestive of amyloidosis. The other point, of course, is that even in aortic stenosis, whenever you see apical sparing and ejection, the disproportionate low global longitudinal strain in presence of good ejection fraction, like in this case, having 60% ejection fraction, global longitudinal strain 10%, and you can clearly see that this patient has aortic stenosis as the arrow points. Think of ATTR. The other thing is on tissue Doppler, when you show extremely low velocities of E, A, and S prime, so-called 555 sign, you should think of ATTR amyloidosis in particular, but amyloidosis in general. This sign has low sensitivity but high specificity, but it's pretty good red flag on echo for those who regularly do echocardiogram. The atrial wall thickness is also a pretty good red flag. And much more important is whenever you do mitral flow pattern or tissue Doppler, and you find that A waves are extremely small, like in this case I'm showing an 83-year female, think of atrial dysfunction, atrial mechanical dysfunction, disproportionate, and think of ATTR cardiomyopathy. The other way of looking at it could be, of course, could be by looking at the acoustic spectral tracking of the left atrium. Here is 555 sign, but we can also actually look at this, as I said, by left atrial reservoir strain. The reservoir strains are extremely low in patients with ATTR amyloidosis. And whenever you see a hypertrophied heart with low LV reservoir strain acoustic spectral tracking, think of amyloidosis. An example, here is an example, 6% left atrial reservoir strain. Typical example, another of LEC2 amyloidosis, not necessarily ATTR, and you can see that the left atrial reservoir strain just 2%. So what is the red flag? A motionless left atrium with preserved left ventricle motion, think of ATTR cardiomyopathy or amyloid cardiomyopathy. Whenever you have motionless left atrium showing hardly anything and the left ventricle is showing much more motion, you, especially in presence of apical sparing, that thing favors cardiac amyloidosis. So here is a study to show that left atrial reservoir strain is more than half lower compared to hypertrophic cardiomyopathy. In hypertrophic cardiomyopathy, they are mostly in the range of 25%, and they are less than 10% in patients with amyloidosis. I would not go through the CMR red flags, but remember, whenever the T1 values are markedly high, extracellular volume is much more. The radiologist has to think in terms of ATTR, the cardiomyopathy, the amyloid cardiomyopathy. To summarize, ladies and gentlemen, we need to diagnose ATTR from red flags, from imaging and biochemical parameters. Future approaches based upon artificial intelligence and machine learning could improve and facilitate the systematic screening of phenotypes of cardiac amyloidosis by automatic detection of red flags from electronic medical records. And thank you very much.
Thank you, Dr. Mohan, for a very exhaustive presentation and a very focused presentation on the red flags. And now may I invite Dr. Sumitra Ray to tell us about the role of ECG, echo, MRI, and biopsy in ATTR cardiomyopathy. Dr. Roy, all yours.
Good evening. Thank you, Dr. Chopra, Dr. Mohan, Dr. Ansu, and all the team present over here. I think, Doctor, the subjects are a bit overlapping, and Dr. Mohan has very nicely elaborated the role of ECG and echocardiogram in suspecting and diagnosis of ATTR cardiomyopathy. I'll touch upon those again and going to MRI and biopsy, and we'll leave the nuclear cardiology bit to Dr. Angshu. So let's start with my first slide. Again, the disclaimer is that these are our own views and sometimes it is personal view, and no company owns any responsibility for that. Now, as we say that, what about the ECG? First, we have already discussed it, but we'll go through it. Diagnostic yield is around 60 to 65%. This is very important statistics. Not more than 2/3 of cases have got any diagnosis in the ECG. Pseudo-infarct pattern, Dr. Mohan has already shown that ECG. ECG showing an old infarct, but mind it, it has to be an old infarct. It is not an acute infarct, ST elevation MI, or evolving infarct. Here, infarct means QS. Basically, infarct means a QS pattern, either in the precordial anterior lead or in the inferior lead. ECG showing old infarct pattern with low voltage. Low voltage is the key word of the whole ECG diagnosis of amyloid. Commonly seen in the wild variety, ATTR around 60%, and the other variety is around 20%. But you see there is a wide variation in that other variety, not the wild variety. Left ventricular failure, as Dr. Chopra has mentioned, without any infarct, and that failure is usually heart failure with preserved ejection fraction, but not necessarily. It could be mildly reduced or even the reduced ejection fraction category. Heart failure with conduction disorders, again it has been mentioned, either left bundle branch block pattern or right bundle branch block pattern, or first degree AV block, or non-specific intraventricular conduction defect is also sometimes seen. Goldberger triad has already elaborated with example by Dr. Mohan, which essentially means a low QRS voltage in the limb lead, normal voltage in the precordial lead, and poor ROA progression in V1 to V3. Now, poor ROA progression V1 to V2 or V3 is a very common ECG finding. And we send the patient to the echo and there is no regional wall motion. We think this is just an ECG variation. But now, this is in mind that it could be a part of Goldberg trial. We have to see whether the voltage is normal there and voltage is low in the limb lead, then we have to think of ATTR cardiomyopathy. RV dysfunction, R wave in the AVR, positive T wave in the AVR. These are the some clues. And isolated atrial fibrillation or lone atrial fibrillation, Dr. Mohan has again shown. Low QRS voltage is not always present, and prevalence varies among the ATTR cardiomyopathy as well as AL variety of amyloidosis. So it is not specific. It is sensitive rather, but not so specific. And I think the right bottom corner is the golden word over here, that EKG shown when talking about discordance between LV wall thickness and EKG. Will come to that later on. Go to the next slide. Yes. Now in the echocardiogram, we see the increased LV wall thickness, which is unexplained. There is particularly no hypertensive heart disease or aortic valve disease, and you get a LV wall thickness with thickening of cardiac valves and interatrial septum, which is rather characteristic of this variety, that is thickening of interatrial septum, again shown with example by Dr. Mohan. Biatrial enlargement when the ventricles are normal, almost like a restrictive cardiomyopathy sort of picture, with small pericardial or pleural effusion may be there. Decreased longitudinal strain, absolute value is less than -15% with relative apical sparing. That is cherry on top, again shown. So the apex is full blown. It is almost like a 3/4 of a circle or a sphere, but the bottom is like a stand, like a tubule. Decreased mitral tissue Doppler, S prime, E prime, A prime velocity, all are below 5 cm/s. Diastolic dysfunction, at least grade 2, that is E by A more than 1.5 or E by E prime is more than 11, and a small A wave in sinus rhythm. Now, as already been shown, I'll just highlight some of the features. Echoapical sparing, as we have seen, like a cherry on top with reduced LV strain. Echo-parasternal short axis, normal view you can see on the left, and amyloid view you see on the right, how they look different. Come to the lower bottom, echo-parasternal long axis showing increased LV wall thickness. There is no asymmetric hypertrophy. It's usually a symmetric hypertrophy. And echo 4-chamber normal view vis-a-vis a 4-chamber amyloid cardiomyopathy view, where very interestingly, both the LV and RV can be equally hypertrophied, including the interatrial septum. So this is very interesting phenomenon, which is not usually seen in hypertensive or aortic valve disease. Now, MRI, if we come, T1 image more than 1400 millisecond is very typical. So there is more tissue, more echoic tissue or more magnetic tissue inside the myocardium. Extracellular volume is more than 42%, which is now a definitive diagnosis, but it's not very, very sensitive, but it's rather very specific. Positive global subendocardial late gadolinium enhancement. So LGE, it shows a positive global subendocardium. So positive global subendocardial in LGE is a sign that something is deposited in the subendocardium tissue. Thick wall ventricle atrium, which can be shown by all modalities. Pleural effusion again can be picked up. Abnormal gadolinium kinetics, typical for amyloidosis. So there are specific kinetic. We may not be so efficient or conversant with that, but radiologists know very well when to suspect the amyloidosis. It has got its very typical kinetic properties with gadolinium. Myocardial nulling prior to blood pool nulling. So myocardium gets negative before the blood pool negative. So these are certain features which are very, very specific to the domain of radiology and imaging. But these can help the radiologist to come up with a more or less definitive diagnosis. But we have to remember that CMR does not definitely distinguish between AL type from ATTR-CM. So this is the fallacy over here. We can diagnose amyloid cardiomyopathy, but we are not sure whether it is ATTR variety or amyloid light chain variety. And why do we need to know that? Because ATTR cardiomyopathy has got a treatment now, tafamidis, whereas AL has got still no treatment available. So we need to distinguish between these two entities very well, because one is treatable, one is not so well treatable. To maximize diagnostic accuracy, CMR parameters should be combined with the other parameters as already discussed by electrocardiogram. Clinical, as Dr. Mohan has very elaborately said, the patient can go to an orthopedician, neurologist, or even gastroenterologist, biomarker and other imaging finding. So if you go over here, you see the cardiac MRI in cardiac amyloidosis. In the first two, you can see the cardiac magnetic resonance imaging showing a 4-chamber and short axis view with left ventricular hypertrophy in the septal region. Corresponding short axis view shows generalized subendocardial LGE, as I was mentioning, not fitting a coronary territory. That is very important. It is pan myocardium, almost like a pericardial disease. When you see the ST changes occurs in all the leads, it shows pericardium rather than myocardium. Here also the same logic applies. Note the reduced signal of the blood pool, which is the dark blood, which is specific for cardiac amyloidosis. In the panel C, it is shown a native T1 mapping analysis, and in E, in the last, it shows both acquired with a field strength of 1.5 Telsa, and you see the difference of cardiac MRI with short axis and LVH. On the right side, you see the cardiac MRI with amyloid positive patient, and if you see the difference from a normal. And if we come to this, consider the gold standard for the diagnosis of cardiac amyloidosis, that is the biopsy. This is the 100% sensitive and specific, 100% accuracy in detection of amyloid, but there are some buts. First but is it is an invasive procedure, and not this expertise is available in many centers, particularly in India. Second, risk for complication, like an injury, like cardiac tamponade, and so on. Requires specialized location and pathologic expertise. Even if you can take a tissue very nicely, very with surgical skill, but you have to send it to get the interpretation. Unable to identify whole heart amyloid burden. evaluate systemic disease burden, or assess response to therapy. So you might pick up a patchy area of amyloid, but you do not know what is the extent of this amyloidosis. You do not know the extent of the amyloid in the whole body, or you do not know whether it will respond to therapy. Particularly, amyloid could be patchy, and you may miss if you hit or take a biopsy from a wrong area. And my last part is that the combination of that immunoelectrophoresis, with urine and with a serum, electrophoresis with immunofixation. What is the role today? Serum protein electrophoresis with immunofixation, it detects clonal immunoglobulin or clonal light chain. It is most sensitive for confirming immunoglobulin production, but there is no monoclonal protein present. Whereas in the urine, electrophoresis and immunofixation, the same thing you can detect, the clonal immunoglobulin and or light chain, but here you confirm the clonal light chain production, not the general immunoglobulin. And there is again no monoclonal protein present. Whereas serum FLC assay, FLC stand for free light chain assay, here you see the ratio of kappa lambda light chain and detects the low level of clonal light chain production. Clonality assume that it is far from 1:1. They are not same proportion. And in the normal range is free light. There are some normal ranges which we do not need to remember, but we need to know that they are there. I stop over here. It's a bit more technical. My talk was that, and we are not very conversant with all these radiological perspective. So I leave for my next speaker to elaborate further with the immunological aspect. Thank you.
Thank you, Soumitra. And as I said, we'll have a discussion at the end. And now it's my great pleasure to invite Dr. Anshu Rajneesh Sharma, who's going to tell us about the most important aspect, the role of nuclear scintigraphy for the diagnosis of ATTR. Anshu, over to you.
Thank you, Chopra sir, for giving me this opportunity in this Heart Failure Association of India's special session on ATTR cardiac amyloidosis. After very nice presentation from Dr. Mohan and Dr. Soumitra Rai, it is my turn to speak on this topic of role of scintigraphy in diagnosis of ATTR cardiac amyloidosis. Can I have next slide, please? First of all, disclaimer. This presentation is the opinion of our experience and expertise. It not necessarily representing the viewpoint or opinion of the sponsor of this program. Next slide. First of all, before starting on role of nuclear scintigraphy, we have to understand the pathophysiology of this disease. Usually, there are immunoglobulins which get misfolded and they get deposited within the myocardium. There are two types of sources of these immunoglobulins. One is from the liver, which we call amyloid transthyretin, and another is amyloid light chain. The source is here plasma cell disorders. Now, these immunoglobulins, they get misfolded and get deposited in the myocardium and it becomes thickened. This is called cardiac amyloidosis. Now, next slide, please. Now, question comes, how a nuclear scintigraphy and how way of scintigraphy we localize this disease. If you see this pathophysiology, there are amyloid fibrils which are deposited in the myocardium. There are two types of amyloid fibrils. You can see here amyloid fibrils are there. Then you have a deposition of the light chains. Then there are inflammatory cells within the tissue, which is macrophages. And then there is a pathophysiology of deposition of microcalcification within the amyloid. Now, these pyrophosphates are basically have a pyrophosphate or phosphate domain. And this pyrophosphate domain get adsorbed at the surface of microcalcification within the pathology of amyloid deposition. So calcification actually attracts the pyrophosphate. If you see the bone scintigraphy pathophysiology, the radiopharmaceutical is diphosphonate, and it get absorbed on the calcium hydroxyapatite crystal of the bone. So it has calcium in the bone. So same way in this pathophysiology of amyloidosis, there is a microcalcification, and this pyrophosphate domain of the radiopharmaceutical get absorbed at the pathology site, and that allows the imaging of the amyloidosis. So this is the pathophysiology. There are many other radiopharmaceuticals which are having some potential to be useful for the imaging of amyloid in the cardiac. One is, these are PET labeled radiotracer. One is 11C PIP. This is fluorine labeled fluorbitabine and fluorine labeled fluorbitabine. Actually, these radiopharmaceutical, the PET tracers have shown potential in Alzheimer's disease. The pathophysiology of Alzheimer's disease or neurodegenerative dementia is the deposition of amyloid in our brain parenchyma. So same pathology probably giving us an insight. Probably these PET tracers may come and handy or can give a potential role in imaging of cardiac amyloidosis also. So this is still in a clinical trial, and hopefully we can get some light on this indication of PET tracers. But today we'll be speaking on technetium-99m pyrophosphate scintigraphy. Next slide, please. Now, as I said, there are various radiopharmaceuticals for amyloidosis. The first and foremost is bone-seeking radiotracer, that is pyrophosphates, which has a phosphonate domain which get adsorbed or the microcalcification of the pathology. Next slide, please. Now, this is a pyrophosphate. It comes in the form of a kit. This is a kit which is supplied by Board of Radioisotope Technology, Bhabha Atomic Research Center, Mumbai. And this vial contains 11.9 milligram of sodium pyrophosphate, 3.2 milligram of stannous chloride, and 4 milligram of tin. So it is ready to use kit. And this is supplied, it is kept in the refrigerator at the 20 degrees centigrade. And this is readily available. It is very easily available, and it is common supply by the BRID. Now, this is not a new radiopharmaceutical. Actually, in 1970s and 80s, this pharmaceutical was used for the bone scintigraphy, and still it is used for the bone scintigraphy. Initially, we used to image the infarct, myocardial infarct, using pyrophosphate cardiac imaging. And this kit is also used for labeling the red blood cells. So we commonly do Muga scan. So for Muga scan, this radiopharmaceutical is used as a cold kit. And for the GI bleed scan, this is also used. So we have a few more indications apart from the cardiac amyloidosis imaging. Next slide. Now, how we go for it? What is the protocol for induction of these patients for scintigraphy? There should be high clinical suspicion of ATTR cardiac amyloidosis, and we have to rule out abnormal light chains by doing the serum studies and serum and urine immunofixation electrophoresis, which our previous speakers, Dr. Somendra Ray and Dr. Mohan, has said that we have to rule out a plasma cell disorder before submitting these patients to technetium pyrophosphate scintigraphy. Next slide, please. Now, this is the protocol. This is a standard operating protocol, imaging protocol for doing a scan. The patient preparation is nothing. Patient can take breakfast and come report to the department. There is no stress scan. This is the rest scan, where we give an injection of technetium-99 pyrophosphate radiopharmaceutical in the range of 10 to 20 millicurie. So it's a big range, but the guideline says between 10 to 20 millicurie you can give it. If you give 10 millicurie, you have to take the patient for longer time. You have to keep patient for imaging time on the gamma camera for a longer time. And if you give 20 millicurie, you can finish the image in a short time. So advantage of more dose, your imaging window becomes fast. And if you are using the less dose, you have to acquire the data. But you reduce the radiation burden to the patient. So advantage and disadvantage are there with both the how you use the doses. Now, time between injection and acquisition. Once you give injection, the imaging is done after 1 hour of the injection. So you do a planar scan after 1 hour of the injection. And if you find there is a blood pool activity means activity within the ventricles. So you take a delayed image at 3 hours and you can perform a tomographic image of the cardiac also. So recommended view is the anterior chest view, but you can take oblique views, left anterior oblique views for separating heart with the ribs, because this pyrophosphate, as I told you, it goes into the bone. But if it is an abnormal myocardium where the amyloid deposits have occurred, then your myocardium is also visualized. So to separate myocardial activity with the bone activity, we can take oblique views. So image type, it is an anterior planar image, or we can do a tomographic images where the gamma camera rotate around the patient and gathers the data, and we can create tomographic slices images just like a CT scan. Patient is positioned supine, nicely lying down on the bed of the patient. The camera is positioned anteriorly over the patient, and we acquire the images in a matrix size of 64 into 64. And sometimes you can take a better image in 256 into 256 matrix. Now, views, as I told, anterior view. At times you can take lateral views and lateral anterior oblique views. And for tomographic data, if you have a one detector, this detector has to rotate 360 degree around the patient, but majority of departments have dual detectors. So both the detectors are 180 degree apart, and each detector rotates 180 degree and completes the acquisition. So these are the basically protocols, the standard operating, the acquisition protocol for doing the scan of chest. Next slide. Now, how we interpret the image? As I said, we acquire anterior image, lateral planar images, and the rotating SPECT images. And then these images are reviewed. We review the images for seeing the myocardial uptake, whether myocardial uptake is absent. If this is absent uptake, it means there is no amyloidosis, there is no pathology, scan is normal. But if there is uptake, then we have to categorize the uptake, whether the uptake is focal or is a diffuse or mixed one, focal and diffuse one. So you can have either no uptake within the myocardium, or you can have an uptake. When there is uptake, it is a pathology. It is a positive scan. Now, question comes how we grade the uptake within the myocardium. So there are semi-quantitative scales and there is a quantitative methods. When myocardial uptake is visually present on SPECT image, then we can calculate heart and contralateral lung ratio, heart to contralateral lung ratio. And if it is more than 1.5, then it is called as ATTR positive. And when the ratio is less than 1.5, we call as a ATTR negative. I will show this in the next example. Next slide, please. Now, this is the visual scoring method. This is also a semi-quantitative method, whereas we are not doing any calculation, we are grading the uptake as compared to the background. What is the background? Is the bone is the background. Uptake within the bone, uptake within the ribs. So when there is no uptake, a normal rib uptake, when there is no uptake in the myocardium, but a normal rib uptake, we call as a grade 0. It is a negative scan. When there is a mild uptake is there, but it is in comparison to rib uptake, it is less than the rib uptake, it is grade 1. And when we call grade 2, when the uptake within the myocardium is equal to the rib uptake, then we call it a grade 2. Here, the diagnosis or planar scintigraphy or pyrophosphate scintigraphy comes in equivocal category. And when there is uptake within the myocardium is significantly more than the rib uptake, then we call it a grade 3. This is highly suggestive of presence of ATTR cardiomyopathy, cardiac amyloidosis. Next slide, please. Now, you see these cartoons, these examples of various stages of amyloidosis within the heart. If you see, this is a normal bone scintigraphy, normal pyrophosphate bone scintigraphy, where we see bones only. If you see here, sternum, These are the ribs which are nicely delineated. These are the kidneys, soft tissue kidneys, because the radio tracer is being excreted through the kidney. So this is a physiological uptake pattern. This is physiological bone uptake pattern. So image is taken after 1 hour of injection, and we can take an optional image after 3 hours also. Now, this is another image where you can see the sternum is there, but there is some faint activity, very inhomogeneous activity within the region of the myocardium, within the region of the heart. So if you compare with the rib, it is just looking like either it is mild or maybe equal. So if it is a mild, slightly lesser, we have done a SPECT study here, tomographic images. If you see, this is the myocardium, this is the heart, and this is the uptake within the myocardium, and you see this is the rib uptake. When the uptake within the myocardium is less intense or lesser than the adjacent rib, then we call it as a grade 1. So it is grade 1 uptake within the myocardium. Now, here if you see, this is again, this is the planar view and this is the tomographic view. If you see here, there is a myocardial uptake. This is sternum, just merging with the sternum, looks like equal to the bone. If you see, the ribs are not nicely seen because the whole activity is seen in the soft tissue. And if you compare here the myocardial uptake, which looks, if you see the adjacent vertebra or the ribs, it looks like either equal or slightly lesser than the rib uptake. So this is equivocal grade 2 uptake pattern. And as we see in the last category, where there is a very intense uptake in the, as compared to this previous image, the myocardium is nicely seen, as you are seeing a myocardial perfusion scan or thallium scan. So same way, nicely myocardium is getting delineated. It is looking better than the sternum, better than the adjacent ribs. So there is an increased uptake. So the myocardial uptake on tomographic images are looking better, more intense as compared to the ribs. So it is a grade 3 pattern of scoring, grade 3 on scoring pattern. Next slide, please. Now, these are the scoring method, how we score visually. Now, this is a quantitative method. In the quantitative method, we calculate the counts coming in the region of heart as compared to contralateral region. So if you see, this is the same image. This is the myocardium, this is the sternum, and this is the contralateral chest area where there is on the right side. So you make a region of interest here over the myocardium or over the left ventricle, and this same area is copied over the contralateral side on the right side of the chest. Now you can see the same ROI region of interest is drawn over the contralateral side. Then computer calculates how much counts are coming, how much the events are being collected within this region of interest, and how many number of pixels are there. Then we calculate per pixel how many mean counts are coming. So if we calculate the ratio of the mean counts in this area number 1, which is over the heart, and the area number 2, which is over the contralateral chest ratio, and that ratio becomes, you see the counts are more here, the counts are less, and this is almost double. So on the pathology side, this is the ratio comes out to be calculated to be 2. So anything above 1.5 ratio is considered highly diagnostic of cardiac amyloidosis. So how we calculate and how we visually score these uptake patterns, we have described in these 2 slides. Can I go for the next slide, please? Now, how we interpret these images, just I have shown you that the overall interpretation of finding is 2 categories: not suggestive of ATR amyloidosis, strongly suggestive of ATR amyloidosis, or equivocal category. Now, not suggestive, when a semi-quantitative score, visual score is 0, means no uptake, or less than 1, or when the heart to cardiac contralateral lung ratio is less than 1. So when these 2 are there, we say the cardiac amyloidosis is not suggestive, or pyrophosphate scintigraphy is negative. When we call it a strongly positive or strongly suggestive, when the semi-quantitative visual score is 2 or 3, means higher 2 scores, 2 and 3, 2 or above, and heart to cardiac, heart to contralateral lung ratio is more than 1.5, then is highly suggestive of cardiac amyloidosis. And equivocal finding, when we are in between, the semi-quantitative visual score is 1, or heart to contralateral ratio is 1 to 1.5. So how we interpret in 3 categories: not suggestive of ATTR, amyloidosis, strongly suggestive ATR amyloidosis, equivocal for the ATR amyloidosis. Next slide. Now, coming to last two slides, this is the meta-analysis published in Journal of Nuclear Medicine 2020, including the 5 studies. And these studies, this meta-analysis has shown the higher sensitivity for technetium pyrophosphontigraphy in diagnosing the cardiac amyloidosis, ATTR cardiac amyloidosis, and specificity is very high. Even some studies have specificity up to 100%. So very high sensitivity and very high specificity, which obviate the need for endomyocardial biopsy in clinically suspicious cases with positive scintigraphy and negative serum study. This is the prerequisite that we have to rule out the plasma cell disorder before subjecting these patients for the scintigraphy. The pyrophosphate scintigraphy is relatively simple. I said only one injection, doing the scan after 1 hour, and optionally at 3 hours. It is widely available. Almost in 300 nuclear medicine departments which are present in India, all can do this pyrophosphate scintigraphy easily. It is readily available. There is no contraindication. As we can see in other modalities, there is no preparation required, and it is a non-invasive technique. So interpretation, we have a semi-quantitative visual scoring system and a quantitative heart to contralateral chest uptake ratio. So absolute quantitation is not possible in this because it's a spec studies, but we have to see the role of serial pyrophosphontigraphy to see the monitor of the response evaluation after the therapy. So this indication we have to explore into the literature. So far, these studies have not come. Next slide, please. So we summarize. Now, early diagnosis of ATTR-CA is important because effective treatment is available, and technetium pyrophosphontigraphy performs exceedingly well as compared to other non-invasive modalities. Thank you so much.
Thank you, Dr. Sharma. That was a great presentation. So I just want to say that amyloid is a great mimic, and that is why the diagnosis is missed. There are over 30 types of amyloid which are present, and the commonest ones are the ones which are associated with renal diseases, and that is why they get missed. Typically, it takes 2 to 3 years before a diagnosis of amyloid is made, because these people go around to different cardiology centers with heart failure. They keep on receiving treatments of heart failure, not realizing that there is amyloid present. Early diagnosis is important because whatever amyloid is deposited, that is not going to be removed. And therefore, if you diagnose it early, there is a treatment available that can prevent further deposition of amyloid and thereby improve the prognosis and the long-term results. None of the markers which are present, like ECG or echo, they are absolutely diagnostic. They are pointers. They help us in diagnosing. For example, the ECG, low voltage may not be present, and other parameters may not be present. So these are pointers. The important thing is to keep it in mind, because there's an old saying, what the mind doesn't know, the eye doesn't see. And therefore, it is important to keep this in mind in situations that Dr. Mohan described. And it should be at the back of our minds so that we can keep this diagnosis in our mind. With that, open to discussion and any questions or any comments. Dr. Mohan?
No, the few things which I want to say is you rightly pointed out that patients are diagnosed quite late, 2 years. That is data from UK Amyloid Center.
From our place will be more.
My own feeling in this country will be much more.
Yes.
The most tragic thing is that patient is seen by cardiologist repetitively, but amyloid does not come in mind.
Yeah.
The last the case which I was showing with the atrial paralysis in a 40 years male, actually was case seen yesterday. And this patient has been there for 2 years with various doctors, the diagnosis of hypertrophic cardiomyopathy. He this time had stroke actually. And we know that these atria are paralyzed and they have a very high chance of either developing atrial fibrillation or even without atrial fibrillation to have stroke. And that is something which you have to remember. So a young guy when came in stroke and then the evaluation done and found out that this is a hereditary actually amyloidosis. ATTR.
How interesting, Dr. Mohan. We have a patient today in our hospital who's had 2 strokes with atrial fibrillation being treated. And then when we investigated, it turned out to be amyloid, but it so turned out to be that it was AL amyloid. And we have to remember that there are about over 30 types of amyloid. And most of the amyloid cases are not ATTR. They are myeloma or renal failure or whatever else it is. But the thing is that if it is ATTR amyloid, at least we have something to offer to them.
I want to make one comment. ATTR amyloidosis far commoner than AL amyloidosis. But AL amyloidosis easier to diagnose. And the reason is very simple. These patients are sicker of the lot. And either multiple myeloma will give the clue or the plasma lactophoresis will give the bench zone protein or things like that will give the clue. What in ATTR amyloid, unfortunately, with 11-12 millimeter wall thickness, HFpEF for heart failure with mildly reduced ejection fraction. Since they are elderly, they always have some degree of coronary artery disease. So even if you do a coronary angiogram, you find borderline lesions. You quite often the tendency is to actually label them as ischemic heart disease and to be treated medically. Unfortunately, the fact remains that we are missing these multiple different ways. I actually, before this, the last case I saw was an 83-year female who was given a pacemaker implantation in the United States, 2014, for 6 sinus syndrome. The patient had thick-walled ventricle. They did not even bother about it. They thought that, and her blood pressure, to be surprised, was 100/60. Their notes say, they should be bothered about 100/60 blood pressure and patient having thick walls and 6 sinus syndrome. Nevertheless, patient had a pacemaker. Pacemaker is functioning fine. She actually comes back, and lo and behold, she comes actually to us with a chest pain evaluation. And the first thing we note actually in chest pain evaluation, we do CT coronary angiogram. There is a thrombus sitting in the left atrium.
Yeah. So the whole thing is what the mind doesn't know, the eye doesn't see.
Yeah. From there, we saw the left ventricle hypertrophy. They almost paralyzed atria and got a pyrophosphate scan done in your hospital. It turned out to be actually the ATTR amyloidosis. Now, the point is that we are missing a large number of these cases, and you sometimes have to insist that the investigation should be done. The case which I'm saying went to a cardiologist of your hospital and had a angioplasty for borderline lesions, because when somebody has dyspnea, angiogram is done, 50-60% lesion, angioplasty. That's the treatment.
Agreed. So, but the point also is that now that we have started actively looking for amyloid, personally, I've been talking to other people in the department, and we have diagnosed ATTR. We have diagnosed amyloidosis in 15 patients. One of them turned out to be ATTR amyloid. Others on immunoelectrophoresis, etc., were all amyloid, AL amyloid. It is a lot more common condition. AL amyloid is a lot more common condition. You are right. We are missing a lot of ATTR, but then if you take the total number of patients who have amyloid, most of them have other diseases, not ATTR.
So, the beautiful study which came from Europe, they actually took unspecified HFpEF patients, consecutive patients, a little over 100, did endomyocardial biopsy of everybody, every single individual, regardless of whatever is the wall thickness. And they found actually 14% patient with ATTR amyloidosis.
But Mohan, the point is that amyloid responsible for the aortic stenosis or not?
No, no,
Because
I'm
we
talking
can't find
HFpEF.
anything.
These are HFpEF patients, not
Okay.
these are HFpEF patients. The point actually, you're right. Actually, the other aspect, of course, is there is a study from. We did quote actually this study which published in November 2021 from All India Institute of Medical Sciences. 45 patients undergoing surgical AVR, and they did endomyocardial biopsy and valve biopsy and showed actually 9.4% of these 3 out of 45 patients had evidence of ATTR. My point is that AL amyloidosis is much easier to diagnose. ATTR is far more common and usually missed for long time because it is a relatively benign course. I'm not saying benign course, relatively benign course. These are people who continue with HFpEF for quite some time, and they keep huffing and puffing. They're getting some treatment. Their blood pressure is low on drug therapy. And you keep saying that, look, this is because of old age, I'll decrease your medicine, so on and so forth. You don't even think of HFpEF. Now, there are multiple studies that have shown that the HFpEF in unselected HFpEF patient, the incidence of actually the prevalence of ATTR could vary from 5 to 29%. I mean, we have studies, especially above the age of 65 years. So my submission again is, we also, in fact, last 4 or 5 years, we have diagnosed far more AL amyloidosis than ATTR, but the fact remains we are missing ATTR much more. And
Mohan, let me ask you, how many of the, I'm sure with your very high index of suspicion, of the patients that you have diagnosed as amyloid, how many have been turned out to be ATTR?
So we have at the moment actually 3 patients with ATTR amyloidosis.
And how many AL amyloid?
So I will talk of last 1 year, 6 about AL amyloidosis, 6 or 7.
Okay, so our data is about 25 patients that we have diagnosed. 24 have been AL amyloid, 1 has been ATTR and very well worked up, and that person is on tafamidis.
Yeah, so the my submission again is, unless you suspect, you would not.
Correct.
So
Correct.
most of them are just going on as regular HFpEF, hypertension, heart disease, HFpEF, obesity, hypertension, diabetes, HFpEF.
Yeah, agreed.
Because you find multiple these risk factors.
Let's get opinion. Sumitra, what do you think?
As I not much time left, I've got very two quick comments.
There's enough time left. You go on.
Is it? Okay.
Yeah.
So two quick comments actually from my side. One is, as Dr. Mohan has explained, these patients can land up in various departments, not necessarily with a cardiologist. So there should be a spread of awareness of what common conditions they can land up, particularly the carpal tunnel syndrome, particularly the gastric sprue and chronic malabsorption syndrome. These are the two important things which other specialties doctors and the neurologist. So neurologist, orthopedician and gastroenterologist, they should have some participation and some spread of knowledge so that they can refer the patient for a cardiological opinion. Number 2 is that, having said and done all the hitches of diagnosis, I still believe for a common practitioner, the most important red flag is when you get an LVH in an echocardiogram with a low voltage complex in the electrocardiogram. This discrepancy, I still think, holds the most important promise in early diagnosis and suspicion. Of course, if the patient is not obese. Obesity is one cause.
With a cherry on top.
Yeah, yes. So if the patient is obese, you get the same set, that LVH by echo and ECG is low voltage. But otherwise, this is the first red signal when a patient should be referred. And then we have got a standard protocol of how to go through it. And as it is transpires, that amyloid is not so uncommon, maybe in India as well, because we are not diagnosing it beforehand. But the type of amyloid, of course, the experience varies from center to center. But pure cardiology cases, perhaps more ATTR and maybe more systemic manifestation with more amyloid light chain type. So there can be some differences. So that's what I gathered from the last 1 hour's discussion.
Dr. Soumitra Ray, I just want to say one thing. You rightly said echocardiography can be the gatekeeper. Unfortunately, echo lab gets referrals from all the specialties. And when you write back in the report that please get a pyrophosphate scan done because this hypertrophy may not be a simple hypertensive heart disease, hypertrophic cardiomyopathy. Believe my words, in my hospital, 99% of the doctors don't follow up that advice when you say get a pyrophosphate scan. We have actually written for pyrophosphate scan in last 6 months to almost 50 patients. And we have not been able to convince a single specialist that a pyrophosphate scan should be done. And we have clearly said that these wall thickness, this.
So that actually shows what I told, that we should spread the knowledge and awareness to all specialties, at least to refer and to follow the advice. That is the first point.
Even amongst indoor patients, they will take your second opinion also from a cardiologist. But whatever the cardiologist written for pyrophosphate scan, that wouldn't be done.
Dr. Mohan, we held 2 meetings with our orthopedics, nephrologist, neurologist in our hospital. And now what happens is when we write back and we pick up a phone and talk to them, not 1%, but 95% of them get a technician pyrophosphate scan done.
This is because
it's a communication which is important.
So it is available with your hospital.
Yeah,
My
it is
hospital
available.
does not have pyrophosphate
That
scan.
makes a lot of difference.
It's a cheap scan. It costs only 4,000 rupees.
Yes.
Yeah, absolutely. You are absolutely right. Our difficulty is we have nearby nuclear labs. Whenever we send for pyrophosphate scan, their standard reply is we don't do it. We have two big.
Mohan, you can easily talk to them because it's a very cheap scan, and it used to be done so much earlier. As I'm sure Anshul your comments on that.
Sir, I think communication is the key, sir. If you tell them we will be sending patient to you for the cardiac amyloidosis, the ATTR exclusion, and kindly organize the technician pyrophosphate in your lab,
I'm sure they'll do it.
This kit is not very costly, sir.
Yeah, it's very cheap.
Very cheap, sir. It is available with the Brit. So only thing is we have to ensure that they have that. Otherwise, doing procedure is very simple. And once you say that I will be sending patient to you, please be ready with pyrophosphate, I think they will oblige you.
One important point I think we should take home for our delegates, what Dr. Sharma has mentioned in his talk, that before sending a patient to pyrophosphate scan, we must exclude that it is not a light chain disease.
Yes.
Otherwise, the whole thing will be messed up. The diagnosis will be clouded.
Sumitra, let me tell you, the protocol is if we suspect something like this, we do a technician pyrophosphate scan and we send at the same time a sample for the hematological test. The advantage of that is if it turns out to be positive and there is a hematological test which points towards light chain and a mismatch between kappa lambda ratio, then you send that person for hematology. And that is what has been happening to a large number of our patients. If you find that there's no mismatch between kappa and lambda, then these are the ones which are picked up for ATTR.
So, Dr. Chopra, I would tell you an interesting thing.
Yeah.
The 22% of the AL amyloidosis patient have positive pyrophosphate scan, 22%.
Absolutely. So that is what I'm saying, that if your cherry on top is positive, if your technician pyrophosphate is positive, it could still be AL amyloid. And given the fact that AL amyloid is much more common than ATTR, that is what I told you, that we have been screening all our patients and only one patient has turned out to be ATTR. All of them have been AL amyloid.
No, Dr. Chopra, then if you can exclude the AL amyloidosis beforehand, then you can save a lot of pyrophosphate and radiation to a normal a person who doesn't require it.
The thing is, you first have to establish that it is cardiac amyloid. See, cardiac amyloid has to be established, and that will be done by technician pyrophosphate. And then at the same time, you try to differentiate, which I will show in my concluding slide. Then you have to decide which way to go. And that will be done with the hematological tests. So can we have the concluding slide, please? So, ladies and gentlemen, after a very interesting discussion, let's come to the final analysis about how we go about diagnosing these conditions. Next, please. Next, please. These are my disclaimers. Next, please. So this is a document that we published in Indian Heart Journal, led by Dr. J.C. Mohan, and many of us were part of this, which was a document about suspecting and diagnosing transthyretin amyloid cardiomyopathy in India. And several people were involved who are intimately involved in the research or diagnosis of this particular condition. Next, please. This is the summary that if you suspect, according to what has been discussed by Dr. J.C. Mohan and others, that there are signs and symptoms, ECG findings, echo, and CMR, which are suggestive of cardiac amyloidosis, you need to do two things. You need to do technetium pyrophosphate scan, which is cheap, plus you need to do hematological tests. Now, after that, the pathways are different. If scintigraphy is negative and hematological tests are negative, it is unlikely that it is amyloid, ATTR amyloid. But if you, for some reason, still have a strong suspicion, then the only method is to do a cardiac biopsy. On the other hand, if your scintigraphy is grade 1 and 3, according to what was shown by Dr. Sharma, but hematological tests are negative, if it is grade 2 and 3, it is likely to be ATTR cardiomyopathy. That means if the hematological tests don't point to adverse kappa lambda ratio and they indicate that AL amyloid is not likely, then it is ATTR cardiomyopathy. Then you have to do genetic screening, because you need to differentiate, is it wild type, which is isolated to that person, or it is hereditary, because that has implications for the rest of the family. So that is very, very important step. But on the other hand, if it is grade 1 and histological tests are negative, then you need to do a histological confirmation, which is the best thing is to do cardiac biopsy, and you need to send a person to the expert center which can do that. Then if come to hematological tests, if scintigraphy is negative, but hematological tests are positive, could it be amyloid, AL amyloid? If CMR is negative, is unlikely, but if CMR is positive, then and scintigraphy is negative, then you probably need to do a histological examination to find out if it is still amyloid. But if hematological tests are positive and scintigraphy is grade 1 to 3, then you need to do a histological confirmation to find out if what is the subtype of the cardiac amyloidosis. So both these tests are equally important, that is scintigraphy and hematological tests, because combined together they give us the indication whether it is AL amyloid or it is ATTR amyloid. Next, please. So it is very important to obtain a definitive diagnosis. So the key recommendations by the panel on patient journeying for red flags that we published in Indian Heart Journal were: ATTR cardiomyopathy should be suspected in younger age groups, more than 40 years, with red flags, considering the propensity of Indian people to develop heart conditions at an age which is much earlier than the Western populations. Heart failure with preserved ejection fraction, left ventricular thickness more than 12 millimeters, global longitudinal strain, aortic stenosis, arrhythmias, cardiac conduction abnormality should be considered as red flags, and that Dr. Mohan has adequately highlighted. And the key thing is thick-walled, non-dilated hypokinetic ventricle should be considered as an important red flag, especially if it is accompanied by atrial abnormalities. Suspect ATTR cardiac amyloidosis with pseudo-infarct pattern with low voltage or decreased voltage and increased left ventricular thickness. That means a mismatch between the ECG findings and the echo findings, atrial fibrillation together with conduction system abnormalities, and then as examined on ECG and echo. And then these are conditions which I'm sure, although they are mentioned, but you're not likely to see them too often in clinical settings, because They are not like to get referred to you very often. But if you have people with carpal tunnel syndrome, lumbar canal stenosis, ophthalmological and neurological manifestation, liver and kidney disorders, edema and swelling should be considered as extra cardiac signs to raise suspicion of ATTR amyloidosis. And you can see why it is called a great mimic, because these conditions are going to be present in 20 other conditions also. ATTR cardiomyopathy should be actively looked for in heart failure patients over 65 years with aortic stenosis, hypotension, normotensive if previously hypertensive. A person is previously hypertensive and suddenly they become normotensive. Think of cardiac amyloidosis. Sensory involvement, that is bilateral sensory neuropathy, autonomic dysfunction. CMR, although should be reserved in cases of ambiguity, but it can provide important clues to suspect ATTR cardiomyopathy. So these are some of the key takeaway points. And with that, I think we would like to conclude this session. And I would like to thank all the panelists for their very, very insightful comments and their contributions. Thank you so much for joining us.
Thank you.